He is going to speak on. He is going to speak on the uh, continuous glucose monitoring in the management of GDM in type 2 diabetes mellitus with pregnancy and latest evidence appraisal. So it is very difficult to, first of all, it's difficult to diagnose, and then after diagnosis, type 1, type 2, GDM, so many varieties, and then many, and after that, what to give and how to monitor, because patients may monitor, may not monitor, it is difficult. And then you are telling you are going to talk about the continuous monitoring of the diabetes during pregnancy. He is a consultant endocrinist at KIMS Sunshine Hospital, Secunderabad, consultant endocrinist Magna Code West, Secunderabad, member of AACE and ESI, ITS and RSSDI, and he is treasurer. Brief background with the list of achievements is he is Legend of the Year 2018 in endocrinology from Times Health Care Achiever. He has been serving as faculty in organized by PHFI since 2010, and his interest is dyslipidemia and metabolic bone disorders. And he is clinical investigator for cardio-diabetic studies like EDGE and then the improved and others. So, TUA, Dulatam and Villi. Okay, start.
Thank you, madam. So, good morning, everyone. Today, I am going to speak on this topic: continuous glucose monitoring in the management of diabetes in pregnancy. This is the flow of my presentation: some basics of continuous glucose monitoring, categories of CGM, and that concept of time in range, and something about freestyle libre, which is commonly used in India, and what is the evidence for usage of CGM in pregnancy, and some guidelines about this TIR, time in range values for pregnancy. So coming to basics of continuous glucose monitoring, and generally traditional approach in the management of diabetes is to start with lifestyle modification, then oral agents, then insulin. And once we start insulin for diabetic patient, self-testing and self-adjustment of insulin dosage is very, very important, and that is the key for good long-term control. And in pregnancy with diabetes, 7-point profile of SMBG is gold standard, and compromised one is 4-point profile. But 7-point profile, which is gold standard, is not that easy. Preaching is easy, in practice it is painful thing. So how to overcome that? For that we have continuous glucose monitoring system. Here we are depending on interstitial glucose estimation where prick is not required. And this continuous glucose monitoring has the potential of providing more accurate information than A1C, and provides more data, so that more opportunities for improving good outcomes. So CGM technology basically has 3 components: sensor, transmitter, and reader. Okay, and main advantage is no need for finger pricks. So sensor measures the glucose, and the reader will collect and displays the collected data. So for glucose estimation, that glucose estimation can be done in arteries, that is ABG, capillaries, that is SMBG, venous, that is routine outpatient plasma glucose, and interstitial glucose by this continuous glucose monitoring. So as expected, some difference will be there, and in general arterial will be more than capillary, capillary more than venous, venous more than interstitial. But with advancement of technology, that gap is narrowing. See the timeline of development of continuous glucose monitoring machines from GlucoWatch to latest one Dexcom G7. So there is one metric called mean absolute relative difference. That gap is narrowing between SMBG and this CGM technology. So this is the sensor kit of Freestyle Libre. So we'll have simple sensor, pack, and applicator. Very easy to apply. It hardly takes 1 minute. Okay. Then after application, how to check the glucose? So wait for 60 minutes, that is 1 hour, and press the home button on the reader. Okay, and bring that reader close to the sensor, that is within 4 centimeter distance you can see the readings. Okay, and advantage of this CGMs are you can see the current glucose level and 8 hours of glucose history. And one more thing is that trend arrow, upper right corner you will see the trend arrow showing if their glucose is going up, down or changing slowly. That is the advantage. And see the daily pattern patient friendly report. So we have horizontal bands that defines the set target glucose range. For example, pregnancy 70 to 120 range is the target, and black line indicates the median glucose level. That means 50% of the readings are above and 50% below that line, and the gray area shows where 80% of glucose readings fall within the 10th and 90th centiles. And hypoglycemic events, the timings easily you can identify. So ultimately with this CGM, 90% Indian population are using this freestyle Libre. So you have the advantage of improving time in range. What is the time in range? I will discuss. Reduce hypoglycemic events, and you can improve HbA1c, quality of life, hospital admissions will come down, and ultimately decreases work absenteeism. Coming to the categories of continuous CGM machines, we have professional and personal systems. Professional, only treating physician can see the readings, whereas personal, both physician and patient can see the readings. Again, in personal CGM you have two varieties, real-time CGM and ICCGM, that is intermittently scanned or flash glucose monitoring. So freestyle Libre comes under this. Of course, freestyle Libre 1, 2, 3 are available. One is available in India, that is FGM, flash glucose monitoring system. And RTCGM we have Medtronic Guardian 3, but it requires calibration. So what is this time in range and why it is measured? So old concept of diabetes management was like fix fasting first, then came the concept of importance of postprandial hyperglycemia, then glycemic triad, then glycemic pentad, that includes minimizing hypoglycemic events and quality of life. Now we have the concept of time in range. So what is this time in range? So it is the percentage of time a person spends within his or her target glucose range. That given range can be vary from patient to patient or depending on situation. For example, non-pregnant, that TIR values are different, set targets are different. So pregnancy with type 2 targets are different, like that. So time in range is an actionable measure that reflects acute glycemic control and can be quickly assessed. So see the importance of this time in range. In this, if you see two patients with same A1C of 7.7, see the glycemic variability. There is a difference. So that you cannot detect in A1C. So that is possible only through CGMs and TIR. So ultimate aim, whether it is pregnancy with diabetes or non-pregnant diabetes, ultimate aim is to maximize that green, that is time in range, and minimize the time above and below the range. That is the ultimate goal. So see the concept of time in range importance. Just a 10% increase in time in range drops the A1C by 0.8%. So we know the importance of A1C. So all microvascular complications of diabetes are directly linked to this A1C. Okay. And these are the international consensus set targets. So non-pregnant generally 70% time in range is the target, and pregnancy with type 1 again 70%, and typical GDM it is 90%. Means 90% of time in a day they should spend in that given target range. For example, if it is 63 to 140, international target is 63 to 140. So 90% of time they should spend in that target. And what is the evidence? For everything we want evidence. So what is the evidence for usage of the CGMs? So in non-diabetics, meta-analysis showed in favor of usage of CGMs. So almost all parameters improved with usage of CGM. This meta-analysis was published in BMJ in 2020. Then what about evidence in pregnancy with diabetes? So most of the trials, RC studies are with real-time CGMs, not with flash CGM. So in India, 90% we are using flash CGMs, not real-time CGM. Okay, real-time CGMs are little bit costly, and only 10% of people are using. Of course, we are extrapolating that data to this flash glucose monitoring systems. See this concept trial. So basically, this is a multicentric randomized control trial with 1:1 randomization. Means 50% using only SMBG, that is finger prick, and 50% SMBG plus CGM. Okay, and primary outcome being estimation of HbA1c at 34 weeks. So patients included are type 1 diabetic, planning pregnancy, and also pregnant individuals. And study observed 7% improvement in TIR. That means 100 minutes per day more time they are spending in given target range. Okay, and that improvement in time in range is translating into better fetal and neonatal outcomes. Of course, some are statistically very much significant, some not, but at least it is not bad for any parameter. So this study summarized improvement in A1C was observed, 7% more TIR was observed, and neonatal outcomes were also better. But if you see the meta-analysis, there is no controversy about HbA1c. All studies showed in favor of usage and significant improvement in HbA1c. But surprisingly, meta-analysis did not show much benefit in that reduction of macrosomia. Something surprising. Of course, more studies are required. And coming to the CGMs and their approval status in pregnancy, right now in India we have this Freestyle Libre 1, that is flash CGM, and one more is Guardian 3. Only 10% are using Guardian 3, that is real-time CGM, more accurate. Every 5 minutes you will get the reading, and no need of reader. So only with Bluetooth pairing will be there to your mobile or laptop, so you can see. So no need of reader in this. And you will get alarms. That is one more advantage. Freestyle Libre 1, which we are commonly using, that has no alarm, and Libre 2 has alarm, and Libre 3 is like Guardian 3. So what is the impact of these trials on guidelines? See the ADA guideline statement. CGM usage in pregnancy with diabetes is like a complementary but not a substitute for SMBG, self-monitoring of blood glucose. So as of now, guidelines are saying like that. So to conclude my talk, CGM in diabetes pregnancy, it is a dynamic measure of glucose estimation, and self-monitoring of blood glucose with that finger stick glucometers is like a taking photograph. That particular time you are estimating the sugar reading, but continuous glucose monitoring is like a videograph. And CGM provides more data, so that more opportunities to improve the glycemic control than SMBG. And time in range provides information which guides in optimal management, and ultimate goal is to maximize time in range and minimize time below and above the range. And you can individualize the goals and improve maternal and fetal outcomes, and you can involve the patient. That is very, very important. You can involve the patient, and so that outcomes will be better. And remember, CGM usage in pregnancy is complementary to SMBG, which is gold standard, but not a substitution. Thank you. With this I will come to Meta.
Thank you very much for giving information about the recent gazettes, this Libre and continuous glucose monitoring. I have one question. Whom do you recommend this continuous weight monitoring in case of pregnancy?
So all high risk pregnancies with diabetes, definitely we can use, madam. And if there is no affordability issue, every patient can use it.
I I think all type 1 diabetes and type 2 where it is not well controlled, or sometimes we think if, blood sugar is well controlled and sometimes stillbirth happens, that you can monitor where exactly the blood sugar was high, that
Yes,
in this
yes, madam.
continuous
So
monitoring.
generally for other than pregnancy, for all type 1s it is advisable. Brittle diabetes, yes, and those who are prone for recurrent hypoglycemic attacks, yes,
for them, yes.
and with bad
The
obstetric
bad obstetric history, it's,
yes, and type 1 diabetes with pregnancy, yes, and type 2 uncontrolled, yes, we can, madam.
so real time is better.
Real time is
Times
better.
better.
Only thing is cost, madam. That transmitter will cost around 60,000.
It's not
And
available.
available. Guardian 3 is available in India. So, but this Freestyle Libre, 90% people are using that Freestyle Libre. It will cost, reader will cost 5,000. That is fixed. That is permanent. Sensor we have to change every 2 weeks. That will cost roughly around 5,000. Means 10,000 per month. 10,000 per month.
Any questions from the audience?
So there are no such guidelines, madam, depending on their comfort. So generally fasting every day and fasting, there are no guidelines, madam, like that.
So you ask them to check almost every day,
Yes, yes, madam.
SMBG.
Yes, yes. So as of now, it is complementary, not a substitute to SMBG. So ideal thing is 7-point profile of SMBG is the gold standard in the management of gestational diabetes.
Yes. And what sort of error would you accept? What percentage error or difference, sorry, I should say.
So definitely
Between
these
SMBG and-
CGM machines requires calibration, madam. So that SMBG is time tested, no doubt about it, and basic minimal knowledge is required for this CGM usage. Unlike SMBG, SMBG is very simple and easy to use.
What percentage difference do you accept before you ask them to recalibrate the machine?
So less than
CGM.
5% difference is acceptable, madam.
Less than 5%. Thank
Acceptable.
You. Thank you.
It's a very nice talk. So, do you see going ahead in the further years, the CGM monitoring actually replacing the routine GRBS monitoring that we're doing, with more trials coming
madam.
up over the years?
Definitely, that is the trend. Trend is going on, and frequently we are using this one. So day by day, that number of patients using this CGMs is increasing like anything.
Okay, thank you.
Thank you, Dr. Vimal and Dr. Sudhakar, for this very enlightening session. And we, all three of us, really enjoyed listening
Thank
to
you,
your
madam.
talk
Thank you.
and very informative. Thank you so much.
Thank you.